robotics in TKR is a hotly discussed topic, and especially youngsters are pretty much interested, or those who are early into practice. So these are my disclosures. Written informed consent for sharing testimonial videos from all the patient has been obtained. So this is important disclosure. So technology, see, my journey with technology started way back in 2006-07 when I had Colibri from RenLab, then Knee3, GPS from Exatech, some semi-automated robots, then switched to fully automated robots, but it was not that encouraging. And definitely earlier versions in the technology, they lacked precision, reproducibility and results. So I was a bit skeptical whether to go for robo, whether it is really worth considering robotics for TKA. Will it make any difference? Is it just a marketing gimmick? Will it add any benefit to the patient? OT time. So probably these are the points any orthopedician will have in the mind before opting for any technology. So I'll try to answer these questions. So robo is a Czech word, friends. The meaning is, it is originated from word robota, and meaning of this word is forced labor or activity. So you are asking someone to work for you. That is the meaning of word robo. Robos are in use in various industries like aviation, military, where you need precision, productivity and efficacy. First time it was used for neurosurgical biopsies in 1988, and same robo with some modification was used for prostate surgery in 1990s. After that, many robos came into picture for GI surgery, abdominal and neurosurgery. But first time, robo was used for arthroplasty at Imperial College London. That robo name was Acrobat. And another robo by Think Surgical, the robo name was Robodoc in early 1990s in California. So current QVIS is a fourth generation from that Robodoc family actually. And so broadly this can be classified into imageless robos or those which are based on some image. So Cori or Velis, they are imageless robos. And QVIS, Mako, Rosa, Miso, they are image-based robots. But Miso and QVIS are fully automated robots, and other are semi-automated robots. Robo adaptation is increasing every year in US, and installations are going up. This study published in 2019 predicts by 2027 almost 50% of total knee arthroplasties will be done using robotic system. Not just in arthroplasty, but robos will be of key use in various other surgeries like high tibial osteotomy, ligament surgeries, for that matter trauma surgeries, spine. So they are there on the horizon, and very soon we will have robos for different surgical procedures. This study published in 2013, and they concluded there is no difference in clinical scores or complications when compared to conventional manual techniques. Another study published, old study in 2011, and they found better alignment accuracy of robotic TK and good clinical results were achieved. Another study published in 2018, conclusion was reduced bone and periarticular soft tissue injuries. So various studies, I will not go into details of each one of them. Now coming to those points which we discussed earlier during the presentation, is it really worth? So Pune being capital of robotic arthroplasty, but we could achieve around 2,500 plus robotic arthroplasties in last 4 years, and it is definitely taken, help us to take our practice to next level. Will it make any difference? But it definitely adds different perspective to your conventional surgery, friend. Definitely adds. Like rotation, alignment, and it is a great research tool. We could publish around 5 papers on different robotic techniques in all index journal in this journey. Is it just a marketing gimmick? No, it definitely adds value to your practice. It is like having good, smart assistant inside theater, and it is for those subset of patients where they believe machine is more important than doctor. Benefit to the patient, less soft tissue releases, less blood loss, implant placement is definitely better, less OPD visits, and improved range of movement. These are the consistent observation in our study. We could finish, 2 hours for bilateral TKA, 4 hours including anesthesia. Complications like pin track fractures, excess resection or neurovascular or soft tissue injuries, we did not notice. But for pin track fracture, we have published this technique, Adkar technique, where for this fully automated QVIS robo, that was the second installation in India actually. There was no one to guide us. And whatever we were told, same technique we followed for initial couple of cases, around 100 odd cases. And then when we noticed around less than 1% cases fracture in the diaphysis, femur diaphysis, we switched to this metaphyseal pin technique. And more than 2,000 cases now, no fractures at all in femoral side. So that is a very good value addition, and we can overcome this complication. Severe deformities, yes, it is possible. I'm going to share a couple of interesting cases here for you. Severe defect, both sides, more on the left side with implant, severe varus and FFD. As you can see, medial side there was just 3 millimeter opening, lateral 8. It was very tight, max Merrill. So basic, gap you need to have is 9 millimeter here. So what we did is we just increased the tibial resection. So some varus on the tibial side we increase, as you can see here, 2 millimeter increase in the tibial resection. Varus on the tibia. To balance the flexion gap, we increase the external rotation. As you can see, external rotation on the femoral side. So for 9 millimeter poly, if you keep it 10 millimeter flexion gap, so that extra 1 millimeter reduces patient's struggle. That allows him early range of movement. So this controlled laxity is not possible in manual techniques, And so with this increase, this resection, I'm just going to forward this. So you can see it here. I have increased the distal femoral dissection, external rotation 3 degrees, varus 2 degrees on the femur, and increase tibial dissection by 2 millimeter. And what was 3 or 8 to begin with, I could achieve 10-10 just before starting the resection. So these definitely adjustments in the bony cuts definitely reduces requirement for soft tissue releases. What we were told is a total knee replacement is a soft tissue surgery. But Robo has essentially made it a bony surgery to minimize soft tissue releases. So these are the post-op x-rays of same patient. So pre-op and post-op. Pre and post videos, we'll skip this. Another patient, severe deformities and post videos, pre, next day after the procedure, 4 weeks post procedure, same sitting bilateral TKA. Another patient, severe deformity, again very tight medially and then flexion also, so we could balance it with adjustment of the bony cuts, post-op x-ray. So we'll skip these videos, subluxated and with implant, pre, post. Severe deformities also we can comfortably handle. Valgus knee, is it possible? That is one question anyone would ask, and many people, they ask me during the presentation. Yes, it is possible. So interesting case, 65-year-old gentleman, bilateral knee pain for 10 years, and these are his pre-op x-rays, classic typical bilateral valgus knee. But kindly note, this, if you see it here, the medial distal, the posterior resection, medial posterior is 5 millimeter and lateral posterior is 9.4 millimeter. So I have, internally rotated the femur to balance the flexion gap. Internally rotated. That was a cultural shock for me. We have been told that external rotation for patellofemoral tracking, but for balancing we internally rotated, and these are the intra-op videos and the picture of same patient. So no issue with patellar tracking. So if you balance it properly, patellar tracking will be all right. And pre and post video of same patient. Another patient, will skip these videos. Pre and post video of the severe deformity. Primary implant without any constraint. That is one beauty of robotics, where we can handle such severe deformities also comfortably with the help of technology. Saw or miller base, doesn't matter, really doesn't matter, any technology. So either you can use a saw or a miller, is your choice. Whatever technique you are using, be thorough. You should use that machine properly. You should know pros and cons of that technique properly. Image based or imageless. So there are certain advantages of imageless robots, where you don't need pre-op CT or X-ray, less radiation, less expensive for the patient, pre-op planning, like you don't need to spend time like this. And especially if there are prior implants in the tibia, femur, then it becomes cumbersome in image-based robots. Disadvantages, you need to locate the hip center on table, malleoli, you need to identify. If there are some tibia and femur cysts, then it is, you can identify them on CT, which is not sometimes visible on X-ray. Okay, so these are the, these points you need to mark and then rotate the femur to identify the hip center. All these points you can skip in image-based robots. Image-based advantages are bony landmarks are clearly visible, and you mark center of the hip, center of the knee, ankle. Cyst, implant size you come to know beforehand. Sagittal plane alignment is definitely, many studies have concluded that sagittal plane alignment is definitely better with image-based robots, and rotational alignment also. So this was the CT image of one of the patient, and then we could arrange our implants accordingly, and this was the intra-op finding and post-op images. So disadvantages again, experience, this radiation and other aspects. But friends, there is definitely learning curve with robotic. It is highly precise if you start using it consistently. More than 98% cases we ended with 9 or 11 poly, minimal poly. That is good achievement, I feel. Less blood loss, less pain, and shorter hospital stay. But you are the boss as a surgeon. Understand pros and cons of the system clearly. Surgery outcome is directly related to information provided by you to the robo, and it will definitely add different perspective to your routine surgery. Thank you very much.